The COVID-19 Immunity Task Force and CanCOVID have partnered on a monthly event series, Research Results and Implications, to offer researchers, policymakers, and Canadians with the latest COVID-19 related results. To learn more about how both organizations have been helping to inform public health policy during the COVID-19 pandemic, please visit our websites at covid19immunitytaskforce.ca and cancovid.ca.
So welcome everyone to the 6th CITF CanCOVID seminar series. My name is Dr. Tim Evans. I am the Executive Director of the COVID-19 Immunity Task Force, and I'll be your moderator today. Before we get started, I've been asked to share some instructions as we're providing simultaneous translation into French, and we'll have a bilingual question and answer period. Bienvenue à tous et à toutes au 5e, je crois qu'au 6e événement de la série.
I believe this is the 6th event of the seminar of GTIC or CTIF, team events, on the task force of the COVID-19 Immunity Task Force. And I'm your moderator today. Before beginning, I've been asked to share a few instructions. We'll be sharing a simultaneous interpretation in French and English and a question and answer session bilingual. At the bottom of your screen,
choose off if you are bilingual and want to only hear the live feed. English attendees, you should select the English option so you can hear the entire event in English. The presentation will be in English, but the question and answer period will be bilingual. When questions are asked in French, our panelists will answer in French if a French-speaking panelist can answer that question. Au bas de votre écran Zoom, vous verrez l'icône.
At the bottom of your Zoom screen, you'll see the icon, globe. Choose off if you're bilingual and you wish only to listen to the direct audio stream. If you're Francophone participant, select the option French to be able to listen to the entire event in French. The presentation will proceed in English, but during the question and answer period, it will be bilingual. When a question is asked in French, our panelists will respond in French, if a Francophone panelist is able to answer that question. Please select your preferred language now.
So I'm assuming people have chosen their preferred language at this point in time, and so we'll begin our substantive deliberations. Let me begin by giving people a brief overview of the COVID Immunity Task Force. We were set up almost 2 years ago at the beginning of the pandemic to look at the trends and levels of immunity across the country. And to date, we've supported about 112 studies. Next. These are the priority areas of research, looking at seroprevalence, immune science, immune testing, vaccine surveillance, safety and effectiveness, and immunogenicity, understanding when boosters might need to be given to different populations, and also modeling immunity. And today, we're going to be focusing on pediatric vaccination. Next slide. We're well into the Omicron wave of the pandemic, and what we've seen in a concerning way is a surge in pediatric hospitalizations. 56% of COVID-related pediatric hospitalizations have occurred in the past 3 months during the Omicron wave. So we've seen, in addition to a surge in infection in younger populations, we've seen many more hospitalizations of children during this period. Next slide. At the same time, we've seen that in contrast to the adult population, pediatric vaccination remains low across the country. Only 57% of children between the ages of 5 and 11 have received one dose of vaccine to date. And this compares or contrasts with 88% of the 12 to 17-year-olds that have received at least one dose. So we have a significant portion of the pediatric population that have not yet been vaccinated. Next. So to illuminate and discuss these issues, we've got an excellent set of speakers today, and I'm going to introduce them here formally because they are not going to be introduced formally afterwards. We have Dr. Manish Sadarangani from who's the director of the Vaccine Evaluation Center at the BC Children's Hospital Research Institute. He's also an associate professor in the Division of Infectious Diseases and the Department of Pediatrics at University of British Columbia. He's a physician lead family immunization clinic at the BC Children's Hospital, and he's a principal investigator in the CITF funded SPRING study. He'll be followed by Dr. Jonathon Maguire, who's a professor in the Department of Pediatrics at University of Toronto. He's a scientist at the MAP Center for Urban Health Solutions, the Li Ka-shing Knowledge Institute, St. Michael's Hospital, a pediatrician in the Department of Pediatrics at St. Michael's Hospital, Unity Health Toronto, and a PI of the CITF funded Target Kids study. Dr. Kate Zinszer, who's an assistant professor at the École de Santé Publique at the Université de Montréal, is a researcher at the Center for Public Health Research, or CRESP, and she's a PI, principal investigator of the CITF-funded ENCORE study. And finally, we'll have Dr. Jim Kellner, who's a pediatric infectious diseases specialist, a professor of pediatrics at the University of Calgary, and a member of the COVID Immunity Task Force Leadership Group, and a leader of the CITF Pediatric Network. So thank you to all of our speakers for agreeing to provide your perspectives on pediatric vaccination. So we're going to move now to Dr. Sadarangani. Manish?
Thanks. Thank you, Dr. Evans, for the introduction, and also thank you to CanCOVID and the COVID-19 Immunity Task Force for inviting me and supporting the work that we do. My disclosures, so I have salary awards from various local and national organizations, and I've received research and project funding from various vaccine manufacturers, and all funds have gone to the University of British Columbia with no personal payments. So on the next slide, I just want to highlight one of the reasons why children are super important and different. And this is some global mortality data showing along the bottom here different age groups from very young infants on the left-hand side all the way to over 95-year-olds on the right-hand side. And the graph just shows the death rate as you go across the age group. And what you can see is in this pediatric age group essentially from 0 to adolescence, there's a dramatic drop in the death rate. And the rate of change here that we see in these first 15 years of life is similar to what we see in the next 70 years. And so it's a pediatric age group is a very, very dynamic, rapidly changing state. And you can't really, you can't extrapolate from adult data to children. And even amongst the pediatric age group, it's important to look at the different age groups separately. And I think that theme will come out as we move forward. So on the next slide, from an immunologic perspective, the specific details of all these aren't important, but I think this graph again shows changes in different elements of the immune system as we go from infancy on the left-hand side all the way to to the older age groups on the right-hand side. So each line represents a simplified form of different parts of the immune system. So the first thing is that there's a lot in the immune system, and it's very complicated, and we hear and you'll see a lot of talk about antibodies, but that's only one part of the immune system. There's a lot else going on. You can also see that actually, while this line is not equally distributed amongst the age groups. So the first 4 sections only take you up to 2 years of life, and you can see all the changes. There's then a relative period of stability during the adult period, and then again towards the later parts of life, once you get to over 60, there's a lot of changes. And so immune responses, and when we think about responses to infection and responses to vaccines, are very, very different in children, and change very quickly from preterm infants, term infants, and in those first 2 years particularly. So on the next slide, and that's really reflected in our vaccine programs. But it's really complicated. Again, it's not simple. It's not just a case of children need more doses or higher doses or lower doses than adults. It's really very specific around each vaccine. And so this is just a selection of vaccines, the way that they are recommended to be used in generally healthy individuals. So clearly for some groups, there are extra doses that are recommended. And I've broken it down here roughly into sort of broad age groups of the infants, so under 12 months in the first column, and then 1 to 11-year-olds, 12 to 17-year-olds, and then adults on the right-hand side. And I've highlighted in the sort of teal color those ages where there's lower doses needed, and in the red, those ages where there's higher doses needed. And you can see that as you go from the younger children to the older children, sometimes you need higher doses as you get older, sometimes you need lower doses as you get older, but even the number of doses can vary. And the age cutoffs for these is different for different vaccines. And so you can see for COVID vaccines, this sort of follows the age cutoffs that I've used overall for the table. For hepatitis B vaccines, for human papillomavirus vaccines in the middle here, the age cutoffs are slightly different. And so it's not a one size fits all. And so despite the fact that the immune system changes in a similar way, the responses to each vaccine is different. And so it's really important that we get vaccine-specific information when we come to a new infection and a new vaccine. Overall, vaccines on the next slide have been, I would argue, probably the most effective health intervention of the last century. This is a timeline going back over the last 60 to 70 years, a number of different diseases on the left-hand side, and each of these rows represents a different disease. The blue circles represent the number of cases of the disease. This particular graph is from data from the United States. And the brown circles show you when vaccines were introduced. And what you can see for all of these, so the writing on the left is a little bit small, but it goes mumps, hepatitis A, rubella. The big one that starts off in the middle here is measles. And you can see that in general, the circles are pretty big, particularly for measles. And when you hit the brown circle, when vaccines are introduced, after that, all of them shrink, not entirely disappearing, but generally they shrink. And so you could see this very dramatic effect that vaccines have had as they've been introduced in the last few decades. And if you look overall at the right-hand side, the amount of blue circle here is much, much less than it was on the left-hand side where we were 70 years ago. So on the next slide, just want to briefly talk about the spring study now that we're doing. So this is a SARS-CoV-2 study in British Columbia, where we've been taking cross-sectional snapshots of children and young adults up to 24 years of age across the province, and then following up those who are COVID positive. It's mostly healthy children. We've been trying really hard to be representative across the province, geographically and in terms of sex and ethnicity. And it's relatively simple. So anyone who's under 25 years of age and living in BC is eligible to be included in the study. And for people who are participating, they are sent a link to an electronic survey, which is completed at home or wherever they want. And then they get sent a kit to collect a few finger prick or heel prick samples of blood that go onto a piece of card, and they get mailed back to us. And then we can test them for antibodies against SARS-CoV-2 in the lab. And I think the great thing about this study and about the whole collaboration and the network that we've developed with the COVID Immunity Task Force is that people can do everything for the study from their own home. They don't even have to leave the house. And this has really completely revolutionized the approach to these studies. So on the next slide, just one slide, of some results. So we've broken it down into the sort of first round of samples that we analyzed back just over a year ago now, and then we're currently in the sort of second phase, and I'm just showing data from the under 10s because the data in the older children and the adolescents are confounded by vaccination. But overall, you could see in the early part of the pandemic, in the under 20s, there were around 3 to 4% of children were showing signs of infection from antibodies in their blood, which was about 2 to 3 times higher than the testing data from British Columbia, and was interestingly was much higher in the 20 to 24-year-olds, around 7% showing signs of previous infection. If we move on a little bit, and while it says March 2022 here, most of this is actually pre-Omicron, and so we're expecting this to significantly increase further when we look at it in the next few months. But even here you can see, interestingly, the under 5s we're getting up towards almost 8% positive, and the 5 to 9-year-olds a slight increase from previously up to around 6%. And it'll be interesting to see how these trends change as we move forward. Thanks, Dr. Evans, back to you.
Thanks very much, Dr. Sadarangani. And your last slide is looking at the evolution of infection from SARS-CoV-2 in children, and showing that certainly into the early Delta wave, there was an increase in the younger children from earlier in the epidemic. And so we're going to continue on with that, what we call seroprevalence. And Dr. Maguire is going to show us some results from the Target Kids study. Dr. Maguire?
Yeah, thank you very much, Dr. Evans. I'm really delighted to be here with you all today. So maybe you could flip to the next slide. So we created a children's cohort study by developing a large primary care research network here in Canada, largely in Toronto. Established in 2008, we've been following about a little shy of 12,000 children over the past 12 years. And when COVID struck, it seemed like a really important thing for us to do to follow these children's experience during the COVID-19 pandemic. So we asked about 1,500 families to be involved and provide us data, both serological data and survey data, initially on a weekly basis, to try to understand what was happening inside the homes over the period of the pandemic. And we normally do our research inside doctors' offices. So this was all a new thing for us, doing it from home and having families contribute data to us. Next slide. And thank you to the Canadian Immunity Task Force for helping us do that. So in terms of seropositivity, we asked families to both collect dry blood spot samples on themselves, so through their finger poke, the parents and the children, starting back in January of 2021 and up to the present time. And what you can see here is the children's seropositivity on the left and the parent seropositivity on the right. The months are on the x-axis across the bottom, and the red parts of the bars are positive tests, either from natural infection or immunity, and the blue is negative tests. So you can see for both the children on the left and the parents on the right that their seropositivity in January was quite low, lots of blue, very little red. And on the right side where the parents are, you can see the proportion of red increasing quite substantially in November. You can see that's likely from vaccination. December, January, and February nearly entirely red. But if we look at the child seropositivity on the left side, we see lots of blue. That the seropositivity in the children seem to be lagging behind the parents. In part, I think because children didn't have access to vaccines, and also because they may not have been infected quite as frequently as their parents. Keep in mind, these are all children under the age of 10 years. So we're talking about fairly young children. Mean age, I think, was around 5 years of age. And you can start seeing the red starting creeping up with the most recent data. The data from December and January is just trickling now, and you can see more of the red recently. Next slide.
Great. Thanks very much, Dr. Maguire. And carrying on then with further seroprevalence results, we have Dr. Zinszer. Dr. Zinszer?
Yes, thanks so much, Dr. Evans, and thank you for the invitation to present our findings today. Next slide. So as was mentioned, I'm a PI on the Encore study, which is very similar to Target Kids in the spring study, in the fact that we have, an electronic questionnaire that we ask parents to complete, as well as we have the blood collection kits that are sent to the home. And we don't perform them on the parents, it's just for the children. And we follow kids over time. And here what we see on this slide is a table, and this is a breakdown of our data that we have to date. So we began our study, we had recruitment at the same time as our first collection, so that we call that baseline. And as you can see on the far right there, it occurred between October 2020 to March 2021. And then our first follow-up was in May 2021 and over that summer period. And then our second follow-up was just before the holidays. The vast majority of our samples for the second follow-up occurred before Omicron became the dominant strain in Quebec. So it was before December 15th. So, and we have a fourth data collection planned for right before the summer break. So it'll be interesting to see how our results differ because we have a pretty decent measure of pre-Omicron with our second follow-up. So going back to the table, what we see here are our seroprevalence estimates based upon different study population characteristics. And on top, we see that we have an average seropositivity. So we started off with 5.8 with our baseline, and it increased over time. And we see the biggest increase happening with our first follow-up. And that was really the alpha phase of the pandemic. And then with our second follow-up, it didn't really increase that much. And we'll talk a bit about seroreversion later on in a few slides. And that's part of what we're seeing. We're just seeing the rate of increase is not as drastic in comparing between the follow-up 1 and 2. But looking across the different follow-up periods, we see that there are differences between male and female participants, with females having a higher seroprevalence. We don't see much of a difference between chronic disease. There's a slight difference for children that have a chronic disease or not. What we did find was that for children whose parents belong to a racial or ethnic minority group, there is quite a difference, which we'll see in more depth in a different slide. But we saw that it was much more prominent with the baseline and then with the follow-up. And then that decreased with our follow-up, with our second follow-up. So you can see the last one, they're quite similar between the two. And that again is related to the seroreversion. So the kids that were initially positive that became negative for IgG. And here we also have it broken down by neighborhood. So for those of you who are not familiar with Montreal, so the different neighborhoods that we have here are the West Island and the Plateau. Those are our more affluent neighborhoods in Montreal, highly educated. And then we have Montreal North, which is one of Montreal's poorest, and it's also one of Montreal's most racially diverse neighborhoods. And then we have Oma, which is Hochelaga, Maisonneuve, and Mercier, which again it's a working class neighborhood, and 1/3 of the population live below the poverty line. So it's interesting to see the differences between the neighborhoods at the baseline, and you can see consistently that Montreal North has the highest seropositivity. So with our last follow-up, it's almost at 17%, and this is compared to 3.2 in the West Island. We can go to the next slide, please. And here we have the same data, but it's broken down by age group. So you see here from 2 to 4-year-olds, 5 to 10-year-olds, and 11 and plus. And then we also have it broken down for our different waves of data collection. So we have our baseline, which is gray, our first follow-up, which is the aqua color, and then we have our darker blue for our most recent. And again, I just want to stress that the second follow-up, despite it saying it's until February, because that's when we received the last sample, the vast majority of our samples were before December 15th. And so what we see here is that we see that there is a difference between ages. It doesn't look like it's statistically significant if we look at, the black bars are the confidence intervals. And we see that the increase is more pronounced from our baseline to our first follow-up. And then with our third follow-up, we actually see a decrease. Again, this is related to a seroreversion. And also we see the follow-up between the baseline and the first follow-up for the 11 and plus, it's not as pronounced as it is for the other age groups. And we think that it's due to the vaccine becoming available for the 12 and up during this time point. So next slide, please. And so this is a table looking at across all of our data together, so longitudinally, and looking at seropositivity, again, looking at seropositivity due to different study population characteristics. And we have it broken down by age group, sex, if the parent belonged to a racial or ethnic minority group, parental education level, as well as household density. So looking at the number of people per bedroom. And if you look across for the columns, we have the adjusted prevalence. So this is adjusted for different confounders. And then we calculated the ratio. So this helps us understand if a level within a characteristic is significantly different. So it just helps us identify if it's statistically significant. And so what we see here is that, and again, this is for our entire study period, we don't see any significant differences in ages. We do see differences in terms of sex. So for female participants, they're 1.4 times more likely to be seropositive. We see also the same, almost the same level of risk for children whose parents belong to ethnic minority, racial or ethnic minority group at 1.4. Interestingly as well, we see not all levels of education from the parents are significant. We see that per master's degree or higher, there is 1.4 times more likely to be seropositive for those children. And we think this is because of during the Delta, there was a lot of outbreaks happening in schools in the plateau area. So we think that's what it's capturing. And then we have the household density. So we see that when we get up to 2 people per bedroom or more, that the risk is 1.6 times more relative to the reference there. Next slide, please. And we also calculated the rate of seroconversion. So this is for participants that were initially negative during our follow-up time period and to when they become positive. And so, for example, if we follow 100 children on average over a year period, 12 more will become positive that were initially negative. And again, we need to be considerate of when, the different variants and the fact that this is calculated pre-Omicron. So again, we're going to recalculate this when we have our data from our next round of collection. We'll see, we anticipate that it'll be of a faster rate than what we have here. The next slide, please. And so, as I mentioned, we also looked at seroreversion. We were noticing that, we had some children participants that were initially positive that became negative. And so we wanted to see this more comprehensively in our study population. And so what we have here is the breakdown for all of those children that were initially positive that had a second sample, whether it stayed positive or whether it then became negative. And so you can see here we have the number, there were 81 of those that seroreverted. So they're initially positive, and then we can no longer detect their IgG in the lab, and so it became negative. And then we have it broken down by age group. And on the right here, we have a Kaplan-Meier curve. And so it's just a nice way to display, we have the display here of the probability of them becoming negative after becoming positive. And we can see that it took on average 191 days. So that's about 6.5 months. So, we see on average that a child who seroreverted, it took about 6.5 months during that time. Next slide, please.
Great. Kate, I think, thanks. We started the presentation with an indication that only 57% of children have had at least one vaccine. And it raises questions about whether there are issues of vaccine hesitancy amongst parents with respect to getting their children vaccinated. So it would be great to get your sense of the extent to which hesitancy is an issue.
Mm-hmm. No, thank you, Dr. Evans, for that question. And we're jumping from serology now into vaccine hesitancy, which is something else that we were quite interested in because as we began the collection, It was before we even thought that there would be vaccines available. And then as vaccines became available for our study population, this is something that we saw was something that we needed to understand and monitor more. And we're seeing, this is a breakdown for our study population. So this is based upon us parents reporting how if they're accepting of the vaccine, if the child has been vaccinated, to not willing to vaccinate their child. And so the red on this graph indicates that they're unlikely to vaccinate. And we see that there's a difference in the parents' acceptance of vaccination and vaccine hesitancy based upon the age of the child. So that's not too surprising. And I should say that for our cohort, we have a rather high level of vaccine uptake for a population of 5 to 11-year-olds. So it's quite higher than the general population. We have about 73% of our children that have been vaccinated that are 5 to 11, I mean. And we have the top, we asked the parents, and we had a list of reasons like why they were hesitant, if they were hesitant to vaccinate their child. And it was, the top 3 reasons were that they were afraid of the side effects of the vaccine. They were afraid because it was a new vaccine, and they also didn't think that their child would become seriously ill if they were infected. So we have one more slide on vaccine hesitancy. If we can go to that slide. And so if we look a little bit more into our data on vaccine hesitancy, we again look at the study population characteristics. And here we have parental education level, the neighborhood, as well as if the parent belongs to a racial or ethnic minority group. And again, so we have 2 follow-up periods where we collected vaccine uptake and hesitancy information. So it was follow-up 1, and that's when vaccines became available for 12 years and older. And during our second follow-up, that was when vaccines became available for the younger kids, so for the 5 and up. And so we have the adjusted prevalence, so the prevalence of vaccine hesitancy for these different study characteristics. And then the column over, again, we're looking at the ratio. So understanding between the different levels within a group, is it significantly different? And so what we see here is that, what we see here are differences between parental education levels, as well as, we don't have significant differences between neighborhoods, despite being different in terms of prevalence. But what stands out is if the parent belongs to a racial or ethnic minority group. So looking at comparing that, and we see that for those parents, they're 3.5 times more likely to be vaccine hesitant in our study population. So thank you very much.
Great, thanks very much, Dr. Zinszer. And Dr. Maguire, you've also, in your target kids study, have been looking at vaccine hesitancy as well. So perhaps you could show us some of what your findings look like.
Yeah, thanks very much, Dr. Evans. We took a bit of a different lens to vaccine hesitancy. Much work has been done on vaccine hesitancy related to the routine childhood vaccinations, and how people conceptualize hesitancy with the other vaccines, non-COVID vaccines, is looking at two beliefs that families might have. One is about the importance of the vaccine. Is it important to me? And the other is about the perception or risk of harm. So on this slide here, we asked families, whether they are convinced of the importance of COVID-19 vaccination. And on the left is the parents who reported strongly agree, and on the right is strongly disagree. And the red bars are how people feel about the vaccine, about themselves, and the blue bars is how they feel about the vaccine for their children. And what you can see in the red box to the right is that about 7% of parents felt that the COVID vaccine was either not important for themselves or neutral, and they felt that way about 19% of the time for the children. So about 1 in 5 parents felt that the COVID-19 vaccine was neutrally important or not important for their children. Next slide. And here you can see a similar slide, but this time is the question: I worry that COVID-19 vaccines will do more harm than good. So this is about the perception, like Dr. Zinszer was talking about, of harm. And on the right side are all the parents that reported strongly disagree, excuse me. And on the left side is strongly agree. So the left side is they believe that COVID-19 vaccines would do more harm than good. The red bars, again, are how parents felt about themselves, and the blue bar is about how they felt about their children. And looking at what parents felt about the COVID-19 vaccine this way, about 19% of parents felt that the vaccine was not safe, that it would do more harm than good, or neutral about it for themselves. And they felt that way about 30% of the time for children. Next slide. Now, I think what's interesting about this is that parents' beliefs about both the importance and safety of the COVID-19 vaccine were systematically different. So for example, parents most of the time agreed between themselves and their children. So if they believed that the vaccine was safe for themselves, about 70% of the time they believed it was safe for their children. Similarly with harmfulness, if they felt that COVID vaccine was harmful for themselves, about 70% of the time parents felt the same about their children. And that makes a lot of sense. However, the disconnect, where parents felt that the vaccine was either not safe for them and not safe for their children, or they had opposing views. It was safe for themselves and not safe for their children. Was kind of interesting because it really fell on socioeconomic lines, and that parents who had lower income, for example, had threefold higher odds of believing that COVID-19 vaccines were not safe for themselves or their children, and fourfold higher odds that they believed the COVID vaccine was safe for themselves but not for their children. Similarly, with non-university education, there was about a 3.5-fold higher odds that parents believed that COVID-19 vaccines were not important for themselves and not safe if they had non-university education. So that's less than post-secondary education. Next slide. And I just wanted to bring up one point that, since we're talking about vaccines, and vaccines are in the context of what's going on with respect to the societal level measures to control COVID-19. The big one that children faced was school closures. And I just want to show you one thing on this slide about school closures. One of the wonderful things about the vaccines is hopefully we can keep the schools open. But when they were closed, this plot I think is very interesting. It shows the adherence to the public health recommendations for the prevention of COVID-19. So in other words, hand washing, keeping 2 meters apart, staying at home, wearing masks, doing the things we were supposed to do. And the school closures, which are in the red arrows, were actually highly associated with everybody doing all those things. On the x-axis at the bottom are days since the pandemic. And so what you can see here is the repeated school closures. The first one, boom, up shot our adherence. We did what we were supposed to do. The next one, further on, the effect of us doing all those things was less. And so on for the third school closure in Ontario. The effect of the school closure on us doing all those things was even less. And it diminished over time of the school closure. So, we use these tools to help, our governments did, to help prevent the spread of COVID-19, and they did work, but their usefulness became less over time, I think underscoring the importance of what we're talking about today with vaccination. Next slide. So at least from our data, the seropositive in children seem to be lagging behind the seropositive for their parents. And I think this is both due to lower infections because we kept the kids safe, keeping them home, and lower vaccination rates because we didn't have vaccines available, and maybe many parents aren't vaccinating their children at the present time. That school closures worked, but they stopped working as well over time, emphasizing the importance of other measures like vaccines to keep our kids safe. And finally, about 20%, 19% of parents had concerns about vaccine importance, and about 30% had concerns about vaccine importance and safety for their children. So big differences in what parents felt about themselves versus their children. Next slide.
Great. Well, thank you very much, Dr. Maguire, for giving us those interesting insights on the importance of vaccines and concerns about safety, and really sort of more nuance in the question of vaccine hesitancy. We're going to now turn to Dr. Kellner, who's going to give us an expert view on the field. In terms of pediatric vaccine safety. Over to you, Dr. Kellner.
Thanks very much, Dr. Evans. Tim, it's a pleasure to be here with my colleagues and all of you today. And thank you to CanCOVID and the COVID-19 Immunity Task Force for putting on this important and relevant webinar. So first, for a disclaimer, I receive research grant and clinical trial funding from a variety of sources, and this funding is all managed and paid to the University of Calgary to support research operations. There's no personal funding that comes to me as an investigator. I have funding from a variety of public agencies is listed there, and as well a variety of pharmaceutical companies, including ones that have been involved in looking at COVID-19 vaccines. I am an investigator, a local investigator on the Moderna pediatric vaccine clinical trial. And a variety of other influential affiliations related to COVID-19 listed there on this slide. So next slide, please. So first I want to say that because of the importance of vaccine safety, there's actually going to be another entire webinar purely on the topic of vaccine safety and coming up next month. And in the link that's provided on this slide, it tells more about that webinar that's coming up. And so today I'm going to, in a discussion on vaccines for children, it's of course relevant to speak about safety. And so I'm going to just make a few highlight comments and then talk about the particular issue of myocarditis, looking at what we know from the observations and scientific literature from around the world on this. So just about a few general comments about the safety of vaccines in children. And one thing to say here is that, you know, there are many COVID-19 vaccines that are either in development or in use around the world. Close to 200 vaccines have been through some form of testing, with over 50 or 60 that have been tested in humans in different locations around the world. And in Canada, there's actually 6 approved vaccines. But when we come down to vaccines for children, we're really just considering 2 vaccines and 1 vaccine platform, and that's the mRNA vaccines for the Pfizer and Moderna vaccines that are being used in children. There are other vaccines in other countries that have either undergone testing or being used, especially in adolescents and some in younger children, but our focus here is on the vaccines that are relevant to Canada, and that's the mRNA vaccines. So in general, adverse events after vaccination in children are uncommon, and they're similar to adults. And just some in the bullets here can highlight some general comments. And again, this will be discussed in much greater detail in the webinar next month. So I'm going through this rapidly, but not with the intention of not giving the detail that's to come. So, but as with adults, the adverse events that can occur typically more frequent after the second dose, but overall less frequent in children than in adults. Most often, these are temporary local symptoms at the injection site. So things like redness, swelling, and pain at the injection site of the vaccine. And then there are generalized symptoms that can occur after vaccines. And again, these are temporary symptoms, flu-like illness, headache, fever, nausea, vomiting, and diarrhea. And then there's the concern about the very rare kind of severe side effects, and including anaphylaxis and or severe allergic reaction. And that severe allergic reaction can occur after any vaccine that is given. And in general, in vaccines, the likelihood of an anaphylactic reaction after a dose of vaccine is somewhere between 1 and 10 per million doses administered. And so what's sort of settled out in the COVID-19 vaccines is from a lot of data observed around the world, is that the likelihood of an anaphylactic reaction is around 5 per million doses administered, and 5 cases. And very often with the mRNA vaccines, these episodes of anaphylaxis occur in people who have a significant allergy history. So that's very, very rare, but it's meaningful and important. And it's part of the reason why anytime anybody gets a vaccination, including a COVID-19 vaccination, there's a period of observation afterwards. And then there's a health history that should be considered about any possible underlying allergic issues. So today, though, in the next few slides, I'm just going to review the important topic of myocarditis, which has come up as a particular topic of interest for children and young adults, especially adolescents and young adults. So next slide, please. So myocarditis, pericarditis, and these terms have become familiar to a lot of people, but through COVID-19 vaccination, myocarditis refers to inflammation of the heart muscle, and pericarditis refers to inflammation of the sheath of tissue that lines the heart and encloses the heart. And so you can get myocarditis alone, pericarditis alone, or myocarditis and pericarditis, so-called myopericarditis. And this is a condition that is known to occur in children anyway, and at any age of life. But in children, the most common way by far that myocarditis or pericarditis occurs is after an infection. And the peak ages that it can occur at are typically late adolescence. You can also see cases rarely in very young infants associated with, in particular, one group of infections called the enteroviruses. And the thing about myocarditis, pericarditis that occurs after infections, it can often be very, very severe. And so it is notable. And the other thing is to say, so the most common age group is late adolescents. And for reasons that are not completely clear, there's a very strong male predominance. 2/3 to 3/4 of cases that occur after acquired infections of any kind occur in males. And certainly we see in infectious diseases broadly that there tends to be a slight male predominance for almost all infections that can occur. But this is a very dramatic male predominance in late adolescence and young adulthood. And the exact reasons why that's so strong, you can speculate about readily, but not clearly understood. So the kind of myocarditis, and if I say myocarditis, I'm always referring to myocarditis and or pericarditis, but just for the sake of not stumbling over my words, I'll just say myocarditis. But the myocarditis that can occur after vaccination, that has been associated with occurring after vaccination, fortunately is mild, and particularly compared with cases that occurred after COVID-19 infection itself, which can be really severe, or other infections. Typically, children will present with having some acute chest pain, maybe short of breath. They may have a rapid heart rate or feel palpitations. And most often it occurs soon after vaccination, 1 to 3 days after vaccination. And to date, this has fundamentally been associated with the mRNA vaccines, the Moderna and Pfizer vaccines. And I put in brackets there the typical dose given for adolescents and adults of these vaccines, the dose of the mRNA. Now, it's not exactly comparable between the vaccines because they're 2 different vaccines, but it is the amount of mRNA, and it's notable, as I'll talk about in the next couple of slides, that the Moderna dose at 100 micrograms of mRNA is significantly higher than the Pfizer dose of 30 micrograms of mRNA. So we know that, again, more common in adolescents and young adults, and I'll show a couple of graphs about that shortly. More common in males compared to females, as I said, 5 times more common in males, approximately, with the various studies. much more common after the second dose of vaccine than after the first dose of vaccine, 6 to 12 times more common. And then again, much more common after COVID-19 vaccination. If you get a case of COVID-19, then, much more common after COVID-19 infection, if you get a case of COVID-19 infection, than it is after vaccination, on the order of 6 times more common. Next slide, please. So now here is data from a couple of sources. One, a journal article from the Journal of American Medical Association, that the link is in there. And then as well, some recent data that from the Centers for Disease Control in the United States. And this is looking then at the likelihood of an episode of myocarditis or pericarditis after vaccination in different age groups. And this is only showing data for the Pfizer vaccine because the Moderna vaccine hasn't been used under the age of 18 as this data was put together. And so this goes all the way down to age of 5. And so in the sets of bars there's 4 sets of bars. And from left to right, there's M, which is males, dose 1. Then in the second set of bars, the highest set of bars there, males, dose 2. Then females dose 1 and females dose 2. And so, and then up the vertical side of the graph there is the incidence of cases of myocarditis, pericarditis per million doses administered. And then the other thing is that the colored bars there show ages. And so just want to highlight that the 5 to 11-year-old children are included in there because from early this year now we have some data for 5 to 11 in the sort of the teal, and then in the red and dark red there's 12 to 15, 16 and 17, and then in the teal and blue 18 to 24 and 25 to 29. So the thing that you can see here, it stands out really dramatically, is that for sure it's more common in males and more common after that second dose. And then the other thing you see here is at the peak in late adolescence, and this is US data, but I'm going to show some Canadian data, and there's data from numerous other countries as well showing a similar thing. So the peak age actually is males in late adolescence, 16 to 17. And then the important thing, and this mirrors what we see again with myocarditis that occurs in regular life caused by other infections. But the important thing is it falls off later in adolescence and young adults, and then it falls off in children. And in particular, the 5 to 11-year-old children, the rate is very low. And you expect that the rate of myocarditis is low in that age. And then as I'll talk about, we're looking at different doses of vaccine. So this does mirror, though, the age and gender distributions for myocarditis after viral infections. Next slide, please. Okay, so now similar colored graphs here. Now this is looking at data from Ontario, and there's a reference provided there. And this is looking at slightly different age groups because not as many cases, and so age groups cluster together. So and this is in males only, and in the teal color there, it's 18 to 24 years of age. And then in the red, it's 25 to 39 years of age. And again, a broader age group, but a smaller population. So I had to cluster the ages together to see this. And it highlights that the myocarditis can occur at any age for sure, even up to the elderly, but there's this peak age of life. And so what this shows now here is highlights how there's a difference between Moderna versus Pfizer. This wasn't seen so strongly in the United States, but it has been seen in Canada and other countries as well. And so again, up the vertical side is the number of episodes of myocarditis pericarditis that have occurred per million doses. And you can see that there's quite a significant difference between Moderna on the right and Pfizer on the left. And and then by age groups, more in the 18 to 24-year-old age group. So the 18 to 24-year-old age group, if you got the Moderna vaccine, 100 micrograms of mRNA, 5 times more likely to get myocarditis than if you got the Pfizer vaccine. And then for 25 to 39-year-olds, the peaks of the bars aren't as high there, but over 7 times more likely to get it after the Moderna vaccine than after the Pfizer vaccine. So next slide, please. Okay, and so now this then is showing the other consideration that comes in, which is the dose interval between vaccines. As everybody knows, in Canada, we've chosen from the start to generally go with longer dose intervals for most people than the dose intervals that came from the clinical trials of 3 and 4 weeks for the Pfizer and Moderna vaccines. And so again, almost from the start, at the beginning, folks were getting it at those dose, especially healthcare workers are getting at that shorter dose intervals. But throughout most of the pandemic, we've been giving longer dose intervals, 8 weeks or more. And so this is, again, data from Ontario, and there's cross Canada data on this as well, that is showing the likelihood of myocarditis pericarditis after the dose interval. So the 3 sets of bars here, and this is just age 18 to 24, both genders, male and female, but showing on the left set of bars there where it says PF, that's Pfizer, so first dose of Pfizer, second dose of Pfizer, that's the lowest you can see the set of bars. And then the next set of bars is Moderna, so you had 2 doses of Moderna, higher for sure there. And then the third set of bars is those who got Pfizer first dose followed by Moderna for second dose. Not nearly as many people, but you can see that getting that second dose of Moderna after first dose of Pfizer from this data shows quite a bit higher likelihood of myocarditis. And again, up the vertical side is cases per million doses administered. So regardless of the vaccine used, the risk of myocarditis pericarditis was, depending on the interval, 65 to 88% lower when the second dose was given 8 weeks or more after the third dose. So that's the other thing to show here. I'm sorry, that the bars across there, the first, second, and third bars, the teal bar under 4 weeks between doses, the red bar 5 to 7 weeks between doses, and the sort of wine-colored bar on the right is 8+ weeks between doses. And so in each cluster of bars, that 8+ weeks is showing a lower likelihood of myocarditis, 65 to 88% lower. So the dose interval makes a difference. So brings up a conundrum, because we know that in older adults, there's probably some benefit to the Moderna vaccine at the higher dose in terms of preventing breakthrough disease. But it seems that the higher dose of vaccine may also be, it is associated with higher likelihood of myocarditis. So next slide, please. Okay, so this just sort of summarizes to summarize what's been done in Canada and elsewhere to look at reducing the risk of myocarditis. So first and foremost, really important, there's ongoing surveillance and follow-up of myocarditis pericarditis cases to understand the severity and any concerns about long-term follow-up. And so far the news is promising on that, but this will continue for a long time to look at this. And so in Canada, the Pfizer vaccine is preferred for those under 30. That's from the NACI, National Advisory Committee on Immunization Recommendations, and all provinces and territories are considering preferentially the use of the Pfizer vaccine under the age of 30. And then it's a lower dose that's given under the age of 12 with the Pfizer vaccine. Instead of that 30 micrograms of mRNA, it's 10 micrograms of mRNA for the children aged 5 to 11. Now, does that lower dose work as well? That is arguable. And then the next thing is the increased recommended routine dose interval between the first 2 doses, with the recommendation, the national recommendation, and I believe that this is what is happening in all provinces and territories, is that the routine interval is 8 weeks between the first and second doses. So by using that lower dose in younger children and using Pfizer preferentially under 30 and giving a longer dose interval, you dramatically reduce the likelihood of myocarditis occurring. And then the final thing is the future possibility for use of different vaccines. As I said at the beginning, there are 6 vaccines recommended for use in Canada. The 2 most recently recommended vaccines are different kinds of vaccines, the Novavax and the Medicago vaccine, or protein-based vaccines, and particularly the Medicago hasn't had any evidence so far to suggest concern about myocarditis, but we don't know that for sure until we get lots of doses that are used. So I think that's it for my slides now, and I'll turn it back to you, Dr. Evans. Thank you very much.
Thank you very much, Dr. Kellner. We're just going to shift now to I think, recognize that research is never a solo endeavor, and I think it's important for the principal investigators here just to give acknowledgement of their colleagues who've been working with them. So I'll begin with Dr. Sadarangani.
Thanks, Dr. Evans. Yeah, I just want to comment really that this has been an incredible collaboration between us here at the Vaccine Evaluation Centre, other investigators at BC Children's Hospital and across the University of British Columbia, and particularly with our public health colleagues at the BC Centre for Disease Control and also the Department of Mathematics. And so it's really brought together a lot of groups. On the next slide is just a photo of our own research group at the VEC last summer in sunnier days in Vancouver, at least. Thanks, Dr. Evans.
Thanks very much. And I think we'll go now to Dr. Maguire.
Yeah, well, thank you very much, Dr. Evans. Really amazing support we've had from the community pediatricians and family physicians here in Ontario, supporting the work that Target Kids has done and the extended team. So and the children and their families for supporting this work. So thank you very much, everybody.
And Dr. Zinszer.
Yes, thanks. As I didn't mention that we initially began our recruitment through the school systems and through daycares in Montreal. So a big thanks goes out to all of the school boards, the schools, the daycares, obviously the children and parents who participate in our study. I'd also like to thank the study staff, Encore study staff, and especially Laura and Katya, who really helped with the presentation today, and the co-investigators as well for their support, and our collaborators in public health. Thanks.
Great. Well, I'd like to extend that thanks to the PIs and their teams, as well as Dr. Kellner. So the bottom line messages, I think, that have emerged from the research that's been presented is that first we're seeing that infection-acquired seroprevalence has gone up over time. And as many have indicated, that we're likely to see quite a significant increase as we move further into the Omicron, the results during the Omicron wave. There are some issues of interpreting trends over time due to issues that Dr. Zinszer talked about with respect to the antibodies detected in the blood disappearing after a certain period of time or being harder to measure. But also we saw very significant risk of infection differentials associated with low-income neighborhoods and households which had higher density occupation, more people per bedroom. So those are, I think, important issues. We touched on the issue of vaccine hesitancy and saw that there is a strong correlation between a parent's vaccination status and the likelihood that they'll vaccinate their children, but they also found that hesitancy is associated with lower parental education, lower family income, and ethnic minority groups. Next slide. In terms of the vaccines, we're seeing that there is really strong evidence that they're protecting children and teens against hospitalization and severe disease, similar to the effectiveness in adults, and that overall vaccines are safe. Very few severe adverse events, and again, levels of adverse events that are at the same or lower than in adults. We heard from Dr. Kellner quite extensively about late adolescent males and the risk of the second dose related to myocarditis and pericarditis. But I think he stressed importantly that the risk of myocarditis, pericarditis is much lower in vaccinated versus unvaccinated kids, meaning kids that have infection. They're more likely to have a higher risk of myocarditis. But also very interesting findings that the lower dose mRNA vaccine seems to be associated with a lower risk, as does a longer dose interval. Again, that important issues related to managing the safety profile of the vaccines in children. Next. And so we do see protection against severe outcomes. We're going to move much more into an understanding of immunity, not only arising from infection, but from vaccination as vaccines continue to roll out. And we, as Dr. Maguire noted, that having vaccines in our armamentarium may help avoid some of the other measures like school closures, which might work in the short term, but are very hard to sustain in terms of non-pharmaceutical interventions adherence. So with that, we're going to move into discussion now. And I have a few questions that we'll ask our panelists just to opine on. Because I think, as everybody will agree, there's a lot that remains uncertain and where we're going to need to continue to generate evidence. So first question is, what measures of vaccine effectiveness or protection should we be focusing on? Is it breakthrough infections or the degree of illness that's either avoided, or is it the possibility of transmission or prevention of transmission to other people in the household? So I'm leaving that open to volunteers from our speakers. Who would like to go take that? Dr. Sadarangani, please.
Sure, I'm happy to start. So, I mean, I think that people may disagree, I guess. I think personally, I think the focus should be on preventing severe illness, hospitalization, and death. I think if we sort of circle back to the beginning of the pandemic, there was a lot of discussion around, you know, reducing the burden on the hospital system and obviously reducing severe illness in those who are most vulnerable. So, and I think that's where the focus should remain, and that includes household contacts. And so I think that, you know, it's a little bit more complicated to that, because obviously, you know, vaccinating some groups may be able to indirectly protect others from severe illness. So I think we need to look at it at that sort of population level of the severe end of the illness spectrum overall.
Sorry, I was talking to myself. I was muted. I was just wondering if there were other panelists who had any other views on that question.
Yeah, just to add to, it's Jim Kellner here. Just to add to what Manish had to say just now is that this thing at the beginning, you know, when we think of what can be prevented or can be aspired to be prevented related to COVID-19 with vaccines, sort of three buckets. That first bucket of, can you prevent transmission so that somebody gets vaccinated and not only are they protecting themselves, but you're actually preventing transmission from person to person. And some vaccines do achieve this. And this was a thing that it seemed early on, that there was some success of the vaccines, good success of the vaccines to potentially prevent transmission from person to person without symptoms. Omicron sort of blew that out of the water in the sense that it's a much more transmissible strain. And while the vaccines have shown really good benefit at preventing severe outcomes, not such a high benefit at preventing transmission. And then back to which I completely agree with the point made by Manish that, you know, we should be focusing on severe outcomes. And then the other was the, you know, prevention of any mild illness. And this is one where you could argue that it's still a little bit open, because one of the concerns you have, of course, after COVID-19 infection is, could you suffer one of the lingering kind of things that can happen, you know, the post-COVID or long COVID syndrome, which can be quite significant, especially for adults. So that would there be any lingering effects? And the question of whether long COVID or post-COVID effects occur more likely after severe disease, where you've been in hospital, or after any symptomatic disease, is still open. And so with concerns that it could occur after mild disease as well. So is it desirable to prevent mild disease, mild symptomatic disease? I think you could argue that it's ideal to prevent mild symptomatic disease, while we're trying to understand better whether what the long-term consequences of mild symptomatic disease are. But again, with Omicron, we found that there's a lot of mild symptomatic disease that occurred, but not the same likelihood of severe disease occurring. So, the speculative part of this is what's going to happen in the future when and if future variants arise, and what's that going to look like. But I completely agree in general that the main focus should be around prevention of severe disease. And in an ideal world, there'd be, with ideal vaccines, there'd be some prevention of mild disease and even prevention of transmission.
Great. Thanks very much, Dr. Kellner. We're going to move to the second one. We've not looked at the children under 5 years of age. Are vaccines needed?
So I can take a first stab at this to say that I think that, again, if we look and Dr. Evans, you showed that slide at the beginning showing the differential impact of the Omicron wave, and that the Omicron variant is different. It's different in how it interacts with our bodies, and it's different in the nature of the disease that it causes, particularly in children. We're seeing quite a shift in the kind of illnesses that you see, and children are suffering from some more typical pediatric clinical syndromes caused by other viruses, and especially children with Omicron have had croup-like illness, the barking cough illness. They've had an illness that is like bronchiolitis, an illness familiar to many people, which is sort of a cross between a pneumonia and an asthma attack caused by a different virus typically. A lot of children have had those illnesses, and then so a different kind of illness, but a lot of children have ended up in hospital. And as you showed, and the numbers vary a bit, but in this short portion of the whole pandemic, well over half of all children ever admitted to hospital for COVID-19 have been admitted. And so children have been more affected. Children don't die often from COVID-19, no doubt about that. But as Omicron has shown, that if you have a highly transmissible strain that's circulating so widely through the community, you'll get a lot more admissions to hospital, a severe outcome worth preventing, and admissions to intensive care units. We also know from the earlier waves, especially the Delta wave, that in places in the world where there weren't much in the way of precautions in place in the community to help prevent transmission, that you saw a lot of children admitted then in those surges. And this especially we saw in some American states, especially states like Texas and Florida, where very few precautions in place in the community, low rates of vaccination. You saw a big jump in hospitalizations and a big surge in hospitalizations in younger children there.
Great.
So children can be severely affected, even if the proportion of children that are severely affected is low. The absolute number of children that are severely affected can be high, and that's been shown with Omicron, especially in Canada and elsewhere, and Delta in other countries.
Great.
The other thing about young children is that we know that the highest likelihood of being admitted to hospital after a case is in children under the age of 1. And this is similar to other infectious diseases. Dr. Sadarangani showed that beautiful slide at the beginning with all the dots showing the magnitude of disease from other vaccine preventable infections. And so much of the worst impact of vaccine preventable infections in general, including COVID-19 in children, is in infancy and early childhood in the first 2 years of life, for sure, 2 to 3 years of life. And so, yeah, children are affected and young children are affected, and they're affected at this similar kind of rate as you see with other vaccine preventable infections. So I think putting it all into context, that it's definitely justifiable to be looking at vaccination of children under the age of 5 if you have a safe and effective vaccine.
Great. Well, thanks very much, Dr. Kellner. We're going to move to the third question, and in part, in the segue, I think, as Dr. Kellner mentioned, is that most areas are removing the non-pharmaceutical interventions, the social distancing, mask wearing, and all of those things. And this relates to the third question, which is, it looks as if we're going to have a significant portion of our childhood population that will remain less than fully vaccinated. And we only, at the moment, only 36% of children 5 to 11 years of age are fully vaccinated, another 21% partially, and then 43 unvaccinated. So I think the question then to the panel is, what are the recommendations for protecting unvaccinated children from SARS-CoV-2 infection? Floor is open.
Thank you, Dr. Evans. You know, I think this is an interesting time with respect to vaccinating young children, because aside from vaccination, none of the other prevention, strategies are particularly palatable right now for people. And I think parents worry about the harms, that have been caused by some of the things that we did as a society to keep our kids safe. So I think those strategies are not likely to be feasible going forward. I also worry, just like others were saying, that traditionally children have borne the brunt of the serious complications from respiratory viruses, and I think that's in part because children hadn't been exposed to respiratory viruses as much as older people. And we're now entering a scenario with COVID-19 that is similar to that children are going to be the least vaccinated, the least immune group of the entire population, putting them in a scenario where they might also bear the front of the serious complications from this particular virus.
Thanks very much, Dr. Maguire. Any other reflections on that question? Okay. Yes, Dr. Zinszer, please.
Yes, I'll just interject, which I completely agree with Dr. Maguire. I don't think there is an obvious solution to protect these children who are partially or unvaccinated effectively, especially given in the context of reopening and loosening a lot of these different measures. And I think we need to think about also in terms of natural immunity. And we're seeing with our study, and other studies have seen this as well, is the seroreversion, which is an indication of immunity waning. And we're looking into this more in depth across our different studies. We have this, a pan-Canadian immunology study that we're doing, so we'll be able to understand, what does if we're not able to detect IgG in our labs, what does that mean in terms of, as Manish mentioned, there's other indications of immune response that we should be also looking at. But I think that is an important thing to consider as well, is how effective is natural immunity over time in terms of protecting kids.
Great. And when you mentioned natural immunity, Dr. Zinszer, you're talking, that's immunity arising from being infected. Is that right?
Yes, thank you.
Okay, thanks very much. Okay, great. Well, listen, our chat, I'm going to skip the fourth question if we need to, because there are questions piling up in the from those who are online. So we're going to move to those now. And I believe I'm supposed to go through these. So these will be, I'm just going to start moving through those. Thank you for the presentation. Live in Ontario, kids are 8 and 5, fully vaxxed. Ontario removed mask mandate on Monday, right after our March break. Our school is really embracing no masking. My kids skip snack at school, wear their N95s, and I pick them up for lunch. They're one of the very few. They ask when they can go to school without masks. I'm at a loss, but I'm very concerned about long COVID kids. Looking for advice, RE, long COVID, and continued masking. Who's going to give some advice?
I could start with a comment, not based in Ontario. I'm in Alberta, where the mask mandates came off some weeks ago. And briefly to both your questions about masks, I think it remains the case that in Canada that people we have to support and respect all citizens to do what they're comfortable with. And I think there's rationale for continuing to wear masks in settings where people are gathering, and especially in settings where there are, close quarters, indoors. The factors about how COVID-19 transmits haven't changed. Indoors, close quarters, not as great air circulation. All those things are concerned. We're at a time now where the reduction in the number of cases has gone way down across the whole country. But some of the indicators people are looking at are leveling off, things like wastewater leveling off. And we see that there's been the start of a rise of cases, especially in some countries in Europe, not necessarily associated with severe outcomes like hospitalization as much, but still some rises in that as well. And the concern people have is, are we going to see the seventh wave coming in, the next wave coming in April? And so if there is a rise in cases, I think we can anticipate that likely to be a rise in cases without the reinstitution of a lot of the public health measures. So I absolutely think people should feel comfortable to wear masks themselves or have their children wear masks where they are most comfortable. And then as well, considering that, there are, one of the challenges that we face with having made the societal decision to take away the various non-pharmaceutical or public health measures, especially masking, has been that there is a whole segment of our population, people on the call possibly, friends, relatives, family members, who are at particular increased risk of COVID-19 and who really don't want to get it even when the incidence is low in the community. People who are immune compromised, have lower strength of their immune system, have significant underlying disease. So there's reasons why people might want to be more cautious than others, and I think we should just be, respectful of that. And I can, in Alberta here, where it's been that way for some number of weeks, I guess if I look at things like grocery stores and malls, that I still have well over half people wearing masks going through grocery stores and malls, and so it's still a thing that I see as widely accepted. In schools, you have children wearing masks, and so I think it's a reasonable thing to continue doing for now. The thing of long COVID, yeah, for sure, is a concern, and as I said, I think in my initial comments, that what we don't know about long COVID, especially in children, is, are you at risk of long COVID or post-COVID effects that linger? If you've had asymptomatic disease, probably not. If you've had mild disease, possibly, but probably less than if you've had more significant disease. We don't know that. For sure, it seems that the number of children who get the really sort of concerning constellation of symptoms that persist, it's real and it's out there. Fortunately, it's a small number of children. And I think it's a thing where there's never going to be perfection in terms of being able to eliminate risk. And where we're getting now in the pandemic, and I don't mean to go on here, I promised a short answer, and this is a longer answer, but this is like with all contagious diseases. There's virtually never a situation where you can come to a place where you've eliminated all risk permanently. So it's a time where individuals and families and society are going to have, going through the process of learning to balance risks, and at a time when there may be less COVID around overall, and at a time when it'll fade into the background but never be completely gone. And you can do the best you can to reduce your risk, but can't eliminate all risk. As Dr. Maguire said, the number one thing you can do, any citizen can do, is get vaccinated. To reduce the risk. Sorry for the very long response.
Can I just make a brief comment as well? Dr. Evans, is that okay? So I agree with what's been said. I'm not going to give specific advice to the individual. I think everyone has to do what they're comfortable with, and we should all be tolerant and respectful of that. I think the only other comment I would say is that, there are other impacts on children that we've seen, particularly sort of the psychosocial mental health impacts. There are some suggestions that, the masking to a little bit impedes educational activities in the classroom and that sort of thing. So I think that we just need to make sure we're looking at the bigger picture of all of the public health restrictions, and not just the impact on the COVID infection itself.
Great. Well, thanks. Thanks to both of you. And we're going to move to another question. My child vaccinated in December, first dose, and then caught COVID in early January. She's not gotten her second dose because there's no clear direction on whether we should wait now or whether she needs it because of her previous infection. Should children who've had one dose and an infection get their second dose? And if so, how long should they wait before getting the second dose? So who has the answers to those questions?
So there's not an exact answer to that. Some provinces do have an approach. In my province of Alberta, we do have an approach to that. It's an important question to ask because we know that you do get some benefit from being from having had a COVID-19 infection. What seems to be known better and better and better over time is that if you've had a COVID-19 infection and you're vaccinated, you have the best possible combination of immunity, whether that infection has come before vaccination, during vaccination, or after vaccination. Having vaccination and immunity from an acquired infection is the best sort of protection that you can have. There's not exact data to guide waiting. In some countries, there has been if you've had COVID-19, there's been this approach to wait, in a lot of countries actually, to wait up to 6 months after you've had COVID-19 before you get any vaccines at all. But what if you've had your first dose? So the approach in Alberta for children over the age of 5 is that if you had a COVID-19 infection before or after your first dose, and you're not immune compromised, and you didn't have the severe outcome of MIS-C, that you wait 8 weeks for that second dose as you would if you hadn't had a COVID infection. So go ahead and get it after 8 weeks. And then if you're immune compromised, but without MIS-C, you might still get it earlier because we recommend immune compromised children to get that second dose earlier, so 4 to 8 weeks. And then if you had MIS-C, on the other hand, which causes a really dramatic immune response and overall response in your body, the recommendation is to wait 3 months afterwards. And MIS-C is that multi-system inflammatory syndrome caused by COVID that can cause very severe disease. And so, and then if it's after you've had 2 doses, you're older, like over 12, and you haven't had your booster, wait at least 6 months as you would otherwise for a booster. So carry on is the bottom line, and it's really only if you and getting your doses. As long as you're waiting 8 weeks between the doses, it's probably fine to just carry on with getting the doses as is. That's the approach in the province of Alberta.
Great, thanks very much, Dr. Kellner. We're going to move to another question. An estimate of 190 days was given for time to seroreversion. I think Dr. Zinszer study looked at that. Do we have preliminary estimates for this that includes post-vaccination? Any idea how long those antibodies will be measurable in the blood after vaccination? Do we have a similar reversion effect? And if so, when?
I can just speak to the fact that we will be looking at this with our next round of data collection. We should have had captured, it will be almost a year since when children were starting to be vaccinated that were captured in our cohort. So we are looking at this, that perhaps there's other panelists that know of the literature that has current literature on this in terms of immunity waning from vaccination.
So any quick views on that from other panelists? I think one part of this is, at least in Canada, we haven't had a very long window to look at the wane potentially in prevalence of antibodies in the blood post-vaccination, because the vaccines were really only rolled out in November, starting to roll out. But we have looked at adults, and we do see, depending on the age and health status of the adult, we see a similar sort of difficulty measuring antibodies in the peripheral blood. after somewhere in the 3 to 6 month range. I think it's very important, as Dr. Zinszer mentioned, that this doesn't necessarily mean that you lose immune protection. It just means that you're not measuring those antibodies in the peripheral blood. And there are other walls of protection of immunity that are still there, and those are being studied and looked at over time. And in fact, this pediatric network is looking at those walls of immunity over time with and without vaccination. Okay, we'll go to another question here. Dr. Kellner, would you be able to comment on recommendations for third doses for adolescents?
Mm-hmm.
NACI has not yet recommended a third dose for average risk adolescents. Might we anticipate a change to this in the near future?
Yeah, so that NACI recommendation, National Advisory Committee Immunization recommendation, made nationally not to recommend it has been out there for a couple of months now. We do know that virtually every province and territory, however, has moved to, because the decision of what to actually do after you have the national recommendations is then interpreted in the individual provinces and territories. And virtually every province and territory has moved to providing that booster dose to all adolescents from 12 to 17 years of age, as opposed to the NACI recommendation, which is just those at highest risk of COVID-19. And NACI's rationale for not recommending it for all adolescents was on the basis of limited data showing the need for a booster. We know very well that the benefit of a booster, especially with Omicron, to prevent severe disease it's much better after a booster over the age of 18, and so there's that pressure that comes. And so the big part of the reason for NACI's hesitation on recommending it was lack of information on both the benefit and the safety. And I did talk in some length, and I won't go through it again, about what we know now and getting more information about the safety of the COVID-19 vaccine in adolescents. And the approach in Canada using the lower dose Pfizer vaccine and longer dose interval makes it dramatically safer. And the limited data that's out so far doesn't seem to show increasing risk of the myocarditis after that third dose. And so on the basis of that emerging evidence around safety, and the concern as Omicron was, sort of running wild, has led most provinces to actually implement a routine vaccination for adolescents over the age of 12. I expect NACI's it may change over time.
Great. Well, listen, I'd like to just thank our four panelists again for sharing your time and your results and expertise with us. We have unanswered questions. We will endeavor to get those answered. We have a record of them in the chat, and we'll try and circulate those as part of the follow-up. You can follow us at the COVID-19 Immunity Task Force through these various mechanisms, and we will be looking forward to further events. As was mentioned, our next event in this series will be at the end of April on the topic of vaccine safety. And so we look forward to your presenting, your joining us for that as well. So with that, we do have publications from the task force that are available that give you a little bit more opportunity to look into these. And we do have a summary of what was presented today in one of those documents. So with that, again, many thanks to our panelists today, Dr. Sadarangani, Dr. Maguire, Dr. Zinszer, and Dr. Kellner. And thank you to everybody who's participated. We look forward to continuing the work on this front and keeping people safe. So all the best, and thank you very much.
So long, everybody.
We would like to thank today's speakers and attendees for their time, as well as the members of our networks for their continued support and participation in Canada's pandemic response. If you are interested in attending our monthly research results and implications events, please visit either website for more information.